Welcome back, everyone, to the deep dive. You know how much we love to dig into complex topics, and today we are tackling one of the most vital and intricate systems in the human body. We are talking about blood.
Yeah, blood. It's so interesting when you really think about it. This one fluid, it's like our protector. It regulates so many things. It transports all kinds of essential stuff. It's truly incredible.
It really is. And you're right. It's amazing how much we kind of take it for granted until something goes wrong, right? And that's exactly what we're going to be exploring today. You brought a ton of information about hematological disorders, and our mission today is to really distill the most crucial insights about what happens when different parts of our blood will face different challenges.
Absolutely. I think you've summed it up perfectly. We've got this huge collection of information about, all sorts of conditions that can affect our blood, and we want to kind of sift through it all and pull out the key things that people really need to know.
Exactly. And we're not just skimming the surface here. We are diving deep into problems with our red blood cells, like the different kinds of anemia. We're going to be talking about platelets and clotting, those tiny but mighty cells that help stop us from bleeding, and even the fascinating role of neutrophils, those infection-fighting white blood cells. I mean, we're talking about everything from thrombocytopenia to neutropenia to a whole spectrum of anemia types, from the common ones like iron deficiency to some really intricate ones.
Exactly. We're going to get into aplastic anemia, sickle cell disease and its crises, acquired hemolytic anemia, hemochromatosis, and polycythemia. And then we'll also be exploring heparin-induced thrombocytopenia, DIC, or disseminated intravascular coagulation, and the inherited bleeding disorders like hemophilia and von Willebrand disease.
That sounds pretty intense.
Yeah, it is. It's a lot to cover, but we're going to break it down into manageable chunks. We'll kind of walk you through the key aspects of each condition, so it's not overwhelming.
Sounds good. Well, let's get started. Let's unpack this, starting with those tiny but essential players in blood clotting, the platelets. We're going to begin with thrombocytopenia, which is essentially when you have too few platelets circulating in your blood. The official definition is a platelet count below 150 by 109 per liter of blood. And as we know, platelets are absolutely crucial for hemostasis, which is just a fancy way of saying the body's way of stopping bleeding when a blood vessel is damaged.
Yeah, and what's really important to understand about thrombocytopenia is that it's not a disease in itself. It's more of a symptom of an underlying problem. It's like a red flag that something is disrupting the normal balance of platelet production, destruction, or distribution in the body. And while there are some rare inherited forms of thrombocytopenia, it's much more common for it to be acquired, meaning it develops due to some other factor or condition.
So what are some of the ways that can happen? How do people acquire thrombocytopenia?
Well, one of the main ways is when the bone marrow, which is where platelets are produced, isn't making enough of them. This can happen for a variety of reasons. Certain types of cancer can affect the bone marrow and disrupt platelet production. There is a condition called aplastic anemia, where the bone marrow just kind of shuts down and doesn't produce enough of any blood cells.
Oh, wow.
And then certain medications, infections, nutritional deficiencies, and even chronic alcohol use can also suppress platelet production in the bone marrow.
So it's kind of like the factory that makes the platelets is either damaged or not getting the supplies it needs to do its job properly.
Exactly. But another major way that people develop thrombocytopenia is when platelets are being destroyed faster than they're being produced. And this can happen in a few different scenarios. Sometimes it's due to contact with artificial surfaces, like during heart surgery or dialysis. The platelets kind of get activated and then destroyed when they come into contact with these foreign materials.
Interesting.
And then there's some specific conditions that can cause increased platelet destruction. One is DIC, which we'll talk about more later, but essentially it's a state of widespread clotting and bleeding. And another is HIT, heparin-induced thrombocytopenia, which is an immune reaction triggered by the medication heparin.
And then even pregnancy and some rare conditions affecting small blood vessels can also lead to increased platelet destruction.
Right. And then finally, sometimes the problem isn't about making too few platelets or destroying too many. It's about where they're located in the body. They can be diluted, for example, if someone receives a massive blood transfusion, or they can get trapped in an enlarged spleen, which is called splenic sequestration.
Wow, so many different mechanisms can be at play here. It's quite complex.
Yeah, it is. It's not as straightforward as you might think, but it's important to identify the underlying cause so you can treat it appropriately.
So let's delve a little deeper into some specific types of thrombocytopenia that you mentioned earlier. You talked about ITP, Immune thrombocytopenic purpura.
Right. So ITP is an autoimmune condition, which means that the body's immune system is mistakenly attacking its own platelets. It's like the immune system is confused and it sees the platelets as foreign invaders. So it produces antibodies that bind to the platelets and mark them for destruction in the spleen.
So the platelets themselves are actually fine. It's just that the body is destroying them inappropriately.
Exactly. And there are actually two main types of ITP: acute ITP and chronic ITP. The acute form is more common in children and often follows a viral infection. It usually resolves on its own within a few weeks or months. Chronic ITP, on the other hand, is more common in adults and it tends to persist for longer periods of time.
And what are some of the clinical signs of ITP? How do you know if someone has it?
Well, in the early stages, someone with ITP might not have any symptoms at all. But as the platelet count drops further, you start to see signs of easy bleeding. Nosebleeds are common, and people might notice that their gums bleed easily when they brush their teeth.
And those little red or purple spots on the skin, those petechiae are a classic sign too, right?
Right. Petechiae are tiny pinpoint hemorrhages under the skin, and they're a hallmark of thrombocytopenia. You can also see larger purplish bruises, which are called ecchymoses. These are basically larger areas of bleeding under the skin. And then in severe cases, people with ITP can have internal bleeding, which can be life-threatening.
So it's important to catch it early and treat it appropriately.
Absolutely. And the main goal of treatment is to raise the platelet count and prevent significant bleeding. Corticosteroids are often used as the first line of treatment. They work by suppressing the immune system and reducing the destruction of platelets.
And if corticosteroids don't work, or for chronic ITP, they might consider removing the spleen, right? Since that's where most of the platelet destruction is happening.
Right. A splenectomy can be an option for some people with ITP, but it's usually reserved for more severe cases or when other treatments haven't been successful.
And you mentioned other treatments earlier, like IVI and rituximab.
Yeah. So IVIGA, intravenous immunoglobulin, is basically a concentrated solution of antibodies that's given intravenously. It can help to temporarily raise the platelet count by blocking the destruction of platelets. And rituximab is medication that targets specific immune cells that are involved in the destruction of platelets. It can be an effective treatment for some people with ITP.
And in those really severe cases, when the platelet count is critically low, they might even give platelet transfusions, right?
Right, but platelet transfusions are usually only given in emergencies to stop active bleeding. They're not a long-term solution because the transfused platelets will also be destroyed by the immune system.
Wow, so many different approaches to managing this one condition. It's amazing how much we've learned about the immune system and how to manipulate it.
Yeah, it's really remarkable. And ITP is a prime example of how a dysregulated immune response can really wreak havoc on the body.
Now, you also mentioned HIT, heparin-induced thrombocytopenia. That one sounds particularly tricky because it's actually caused by a medication that's supposed to prevent clotting.
Right. HIT is a very unique type of thrombocytopenia because it's triggered by the use of heparin, which is a commonly used blood thinner. It's an immune reaction that's very specific to heparin.
So how does it work? How does heparin end up causing low platelets?
Well, it involves a protein in the blood called platelet factor 4, or PF4. When heparin binds to PF4, it forms a complex that can trigger an immune response in some people. And their body produces antibodies that target this heparin PF4 complex. These antibodies then bind to platelets, causing them to become activated and clump together. And this leads to a couple of major problems. First, the activated platelets are more easily destroyed by the spleen, which leads to thrombocytopenia.
So you're giving someone a blood thinner, but their body is actually destroying platelets, which are needed for clotting.
Exactly. It's a paradox. And the second problem is that these activated platelets also release substances that promote clotting. So people with HIT actually have an increased risk of developing blood clots, even though they're on a blood thinner.
That's terrifying. So it sounds like early recognition and management of HIT is absolutely crucial.
Absolutely. The most important thing to do if you suspect HIT is to immediately stop all heparin. That includes both unfractionated heparin and the low molecular weight heparins.
No more heparin. Got it. And then what do you do once you've stopped the heparin?
Well, you need to start a different type of blood thinner that doesn't cross-react with the HIT antibodies. There are medications called direct thrombin inhibitors, like dabigatran, that are often used. Warfarin can also be used, but only after the platelet count has recovered to a safe level.
And you mentioned that platelet transfusions are generally not recommended in HIT, right? Why is that?
Yeah, that's right. Giving platelets to someone with HIT can actually worsen the clotting problem because the transfused platelets will also become activated by the HIT antibodies.
Hmm.
So it's kind of like adding fuel to the fire.
That makes sense. So it's really important to differentiate HIT from other types of thrombocytopenia because the treatment is so different.
Absolutely. And it's also important to remember that HIT can occur even after someone has been on heparin for a while. So you always have to be vigilant and monitor patients closely for any signs of thrombocytopenia.
All right, let's move on to a really complex and often serious condition called disseminated intravascular coagulation, or DIC for short. From what I understand, it's basically a dysregulation of the entire clotting cascade, which can lead to both widespread clotting and bleeding at the same time.
Yeah, DIC is a real mess. It's not a disease in itself. It's more of a syndrome that can be triggered by a variety of underlying medical conditions.
So what kind of things can trigger DIC?
Well, a lot of things. Severe infections like sepsis are a common trigger.
Hmm.
Certain types of cancer can also trigger it. And then obstetric complications, severe trauma, burns, and even snake bites can also cause DIC.
Wow, that's quite a range. So basically, anything that causes a massive inflammatory response or releases a lot of tissue factor into the blood can potentially trigger DIC.
Exactly. And the problem in DIC is that the normal clotting process goes haywire. It's like the body's clotting system gets turned on full blast, and then it can't turn itself off.
So what happens is that the body starts forming lots of tiny clots in the small blood vessels throughout the body.
Right. And this uses up all the available clotting factors and platelets. So even though there's a lot of clotting happening, the body is also losing its ability to form clots when it really needs to. And that's what leads to the bleeding problems.
So it's like clotting until you can't, then bleeding everywhere.
Yeah, that's a good way to put it. It's a real catch-22 situation.
And I remember reading that a key diagnostic indicator in DIC is an elevated D-dimer level.
Yeah, that's right. D-dimer is a breakdown product of fibrin, which is the main protein that forms blood clots. So when there's a lot of clotting and then breakdown of clots happening, the D-dimer level will be elevated.
And clinically, you see both the effects of the clotting and the bleeding, right?
Right. So on the one hand, you have the microvascular thrombosis, which is the formation of those tiny clots in the small blood vessels. This can lead to a whole range of problems depending on where the clots are forming. You can have organ damage, gangrene, stroke, respiratory distress, and even kidney failure.
And on the other hand, you have the bleeding problems, which can be just as serious.
Right. People with DIC can have bleeding from just about anywhere. They can have nosebleeds, bleeding gums, bleeding from IV sites, and internal bleeding.
It sounds like a real nightmare to manage.
Yeah, it is. It's a very complex and challenging condition to treat. The first and most important step is to identify and treat the underlying cause of the DIC. And then you have to provide supportive care, like giving blood transfusions to replace the lost clotting factors and platelets. And sometimes you might even have to give heparin, even though it seems counterintuitive, to try and control the excessive clotting.
Wow. So it's a very delicate balancing act. You're trying to stop the clotting, but you're also trying to prevent bleeding. It's amazing how the body can even survive something like this.
Yeah, it is. But it just goes to show how important it is to maintain a healthy balance in all of our bodily systems.
All right, let's shift gears now and talk about neutrophils, which are those amazing white blood cells that help protect us from infection. And specifically, let's talk about neutropenia, which is a condition where you have too few neutrophils in your blood.
Yeah, so neutrophils are like the first responders of the immune system. They're the ones that rush to the site of an infection and engulf and destroy the invading bacteria or other pathogens. And when you don't have enough of them, you're much more susceptible to infections.
And neutropenia is defined as a neutrophil count below 1 to 1.5 billion per liter of blood.
Right. And if the count drops below zero point 0.5 billion, it's considered severe neutropenia. And the lower the count, the greater the risk of infection.
So it's not just the number of neutrophils that matters, it's also how low that number is.
Exactly. And one of the tricky things about neutropenia is that it doesn't always cause any obvious symptoms. People might feel a little tired or run down, but often the first sign of a problem is a fever.
A fever. So no classic signs of infection like redness, swelling, or pus.
Not necessarily, because the body doesn't have enough neutrophils to mount a normal inflammatory response. So a fever might be the only clue that something is wrong.
Wow. So it's really important to pay attention to any fever in someone with neutropenia, even if there are no other signs of infection.
Absolutely. A fever in someone with neutropenia is always considered a medical emergency until proven otherwise.
And there are a lot of different things that can cause neutropenia, right?
Right. There are a whole host of potential causes. Some are medical conditions, like autoimmune disorders or leukemia. Some are infections, both bacterial and viral. And then a lot of medications can cause neutropenia as a side effect, like chemotherapy drugs, some antibiotics, and even some over-the-counter pain relievers.
Wow. It seems like almost anything can potentially cause it.
Yeah, it's pretty common, especially in people who are hospitalized or have weakened immune systems.
So how do you manage someone with neutropenia?
Well, the most important thing is to prevent infections from happening in the first place. That means meticulous hand hygiene, avoiding contact with sick people, and being careful about food preparation. And if someone with neutropenia does develop a fever, they need to be seen by a doctor right away.
And they'll probably start them on broad-spectrum antibiotics right away, even before they know what the infection is.
Exactly, because you don't want to wait and see what happens when someone with neutropenia has a fever. You need to treat it aggressively right from the start.
And sometimes they might even use medications called growth factors to try and stimulate the bone marrow to produce more neutrophils, right?
All right. Growth factors can be helpful in some cases, especially if the neutropenia is severe or long-lasting.
Okay, let's move on to anemia now. Anemia is a broad term that basically means there's a deficiency in red blood cells, which are the cells that carry oxygen throughout the body. And it can manifest in a lot of different ways, right?
Right. Anemia is not a single disease. It's a condition that can have many different underlying causes. And depending on the cause, the symptoms and the treatment will vary.
And the notes emphasize that anemia is really a sign of an underlying problem rather than a diagnosis in itself.
Exactly. It's like a warning light on your car's dashboard. It tells you that something is wrong, but it doesn't tell you exactly what's wrong.
And to figure out the cause of the anemia, they'll usually do a complete blood count, or CBC, which looks at all the different types of blood cells. And then they might do other tests like a reticulocyte count and a blood smear, right?
The reticulocyte count tells you how many young red blood cells are being produced by the bone marrow. And the blood smear allows you to look at the red blood cells under a microscope to see if there are any abnormalities in their size, shape, or color.
And all of this hopes to pinpoint the underlying cause of the anemia.
Exactly. And once you know the cause, you can treat it appropriately.
So let's talk about some specific types of anemia, starting with iron deficiency anemia, which is the most common type worldwide. What exactly is going on in iron deficiency anemia?
Well, as the name suggests, it's caused by a lack of iron in the body. Iron is essential for making hemoglobin, which is the protein in red blood cells that carries oxygen. So if you don't have enough iron, you can't make enough hemoglobin, and your red blood cells can't carry enough oxygen to your tissues.
And this can happen for a few different reasons, right? Like not getting enough iron in your diet, having problems absorbing iron, or losing blood.
Exactly. Those are all common causes of iron deficiency anemia, and certain groups of people are at higher risk, like pregnant women, infants and young children, and people with certain medical conditions that affect iron absorption or cause blood loss.
And what are some of the symptoms of iron deficiency anemia?
Well, the general symptoms of anemia, like fatigue, weakness, and shortness of breath, are common. But people with iron deficiency anemia might also have some more specific symptoms, like pale skin, brittle nails, and a craving for non-food items like ice or dirt.
That's strange. A craving for dirt.
Yeah, it's called pica, and it's thought to be related to the body's craving for iron.
And how do you diagnose and treat iron deficiency anemia?
Well, a CBC will usually show a low hemoglobin and hematocrit, and the red blood cells might be smaller than normal. And then you can do iron studies to measure the levels of iron in the blood.
And if it's confirmed, the treatment is pretty straightforward, right? Just give them iron supplements.
Right. Usually, oral iron supplements are enough to correct the deficiency. But sometimes, if the anemia is severe, or if there's a problem with iron absorption, they might need intravenous iron. And of course, it's important to address the underlying cause of the iron deficiency, like treating any blood loss or improving iron absorption.
Okay, let's move on to another type of anemia, megaloblastic anemia. This one's a little more complicated. What's going on in megaloblastic anemia?
So megaloblastic anemia is caused by a problem with DNA synthesis in the red blood cells. And this leads to the production of abnormally large red blood cells called megaloblasts.
Megaloblasts, those sound big.
Yeah, they are. And they're also fragile, so they break down more easily than normal red blood cells.
And what causes this problem with DNA synthesis?
The most common causes are deficiencies in vitamin B12 or folate, which are both essential for DNA synthesis.
And these deficiencies can happen for a variety of reasons, right?
Right. Vitamin B12 deficiency can be caused by a lack of intrinsic factor, which is a protein that's needed for vitamin B12 absorption. This can happen in pernicious anemia, which is an autoimmune condition that destroys the cells in the stomach that produce intrinsic factor.
Wow, so the body is attacking itself again.
Yeah. Autoimmune diseases can affect just about any organ in the body.
And besides pernicious anemia, what are some other causes of vitamin B12 deficiency?
Well, it can also be caused by certain gastrointestinal conditions that affect vitamin B12 absorption, like Crohn's disease or celiac disease. And it can be caused by certain medications, like proton pump inhibitors, which reduce stomach acid and can interfere with vitamin B12 absorption.
And what about folate deficiency? What causes that?
Well, the most common cause is simply not getting enough folate in your diet. Folate is found in leafy green vegetables, legumes, and fortified grains.
So it's important to eat a healthy diet.
Absolutely. And then there are certain medical conditions that can increase the body's need for folate, like pregnancy and certain types of cancer. And some medications can interfere with folate absorption, like methotrexate, which is used to treat cancer and autoimmune diseases.
And what are the symptoms of megaloblastic anemia?
Well, besides the general symptoms of anemia, people with megaloblastic anemia might also have neurological symptoms, like numbness, tingling, and difficulty walking. This is because vitamin B12 is also essential for the health of the nervous system.
So it's not just the blood that's affected.
Right. And these neurological symptoms can be permanent if the vitamin B12 deficiency is not treated promptly.
Yikes. So how do you treat megaloblastic anemia?
Well, the treatment depends on the cause. If it's due to a vitamin B12 deficiency, then they'll need vitamin B12 supplements. And if it's due to a folate deficiency, then they'll need folate supplements.
And if it's due to pernicious anemia, they might need lifelong vitamin B12 injections, right?
Right, because they can't absorb vitamin B12 from their diet.
Okay, let's move on to anemia of chronic disease, which is another common type of anemia. What's the story with this one?
Anemia of chronic disease is associated with certain chronic medical conditions like infections, inflammatory diseases, and cancer. And it's thought to be caused by the body's response to these conditions.
So the body is essentially sabotaging itself.
In a way, yes. The inflammation associated with these chronic diseases can interfere with the production of red blood cells and shorten their lifespan.
And the symptoms are similar to other types of anemia.
Right. Fatigue, weakness, and shortness of breath are common. But the anemia of chronic disease is usually mild, and the symptoms are often overshadowed by the symptoms of the underlying disease.
So how do you treat it?
Well, the main focus is on treating the underlying disease. And sometimes, if the anemia is severe, they might give blood transfusions or erythropoietin, which is a hormone that stimulates red blood cell production.
Okay, let's talk about anemia due to acute blood loss now. This one's pretty self-explanatory, right? You lose a lot of blood, you become anemic.
Right. But there's more to it than that. The severity of the anemia depends on how much blood is lost and how quickly it's lost.
So if you lose a lot of blood very quickly, like in a traumatic injury, that's much more serious than losing a smaller amount of blood over a longer period of time.
Exactly. And if you lose a lot of blood quickly, you can go into shock, which is a life-threatening condition.
And the treatment for acute blood loss is pretty straightforward, right? Stop the bleeding and replace the lost blood.
Right, that's the first priority. They might give intravenous fluids or blood transfusions to restore blood volume, and then they'll need to identify and treat the source of the bleeding.
Okay, let's move on to aplastic anemia now. This one sounds pretty scary. What is aplastic anemia?
Aplastic anemia is a rare but serious condition where the bone marrow stops producing enough blood cells.
So it affects all the different types of blood cells, red blood cells, white blood cells, and platelets.
Right. It's called pancytopenia, which means the deficiency of all blood cell types.
And what causes it?
Well, in most cases, the cause is unknown. But it's thought to be an autoimmune condition where the body's immune system attacks the bone marrow.
So the body is attacking itself again.
Yeah. It's like the immune system is misfiring.
And what are the symptoms of aplastic anemia?
Well, because all the blood cell types are affected, you see a combination of symptoms. You have the symptoms of anemia, like fatigue and shortness of breath, because of the low red blood cell count. You have an increased risk of infections because of the low white blood cell count. And you have an increased risk of bleeding because of the low platelet count.
So it's a triple whammy.
Yeah, it's a very serious condition.
And how do you treat it?
Well, if the cause is known, like exposure to a toxin, then they'll try to remove the toxin. But in most cases, the treatment involves suppressing the immune system with medications or doing a bone marrow transplant.
A bone marrow transplant. That sounds pretty intense.
Yeah, it is. But it can be a life-saving treatment for people with severe aplastic anemia.
Okay, let's move on to sickle cell disease now. This is a genetic disorder that affects the shape of red blood cells, right?
Right. In sickle cell disease, the red blood cells are sickle-shaped or crescent-shaped instead of being round and flexible.
And this shape change is caused by a mutation in the gene that codes for hemoglobin, which is the protein that carries oxygen in red blood cells.
Exactly. And the abnormal hemoglobin in sickle cell disease is called hemoglobin S.
And these sickle-shaped red blood cells cause problems because they can get stuck in small blood vessels and block blood flow, right?
Right. This blockage of blood flow is called a vaso-occlusive crisis, and it can cause severe pain, organ damage, and even stroke.
And besides causing blockages, the sickle-shaped red blood cells are also more fragile and break down more easily than normal red blood cells, leading to anemia.
Right. And the breakdown of red blood cells also releases a substance called bilirubin into the blood, which can cause jaundice, a yellowing of the skin and eyes.
So it's a multifaceted problem, and there's no cure for sickle cell disease, right?
No, there's no cure. But there are treatments that can help manage the symptoms and prevent complications.
Like pain medications for the vaso-occlusive crises.
Right. And they might give blood transfusions to increase the number of normal red blood cells and reduce the concentration of sickle cells. And there's a medication called hydroxyurea that can reduce the frequency of vaso-occlusive crises.
And what about acquired hemolytic anemia? How is that different from sickle cell anemia?
Well, in sickle cell anemia, the problem with the red blood cells is intrinsic, meaning it's caused by genetic defect in the hemoglobin molecule. But in acquired hemolytic anemia, the red blood cells are normal, but they're being destroyed prematurely by some external factor.
So what kind of external factors can cause this?
Well, there are three main categories: physical destruction, immune destruction, and destruction by infectious agents or toxins.
So physical destruction could be something like a mechanical heart valve that's damaging the red blood cells as they pass through.
Exactly. Or it could be damage to the blood vessels themselves, like in severe burns.
And immune destruction could be something like a transfusion reaction, where the body's immune system attacks the transfused red blood cells.
Right. Or it could be an autoimmune condition where the body's immune system attacks its own red blood cells.
And destruction by infectious agents or toxins could be something like malaria, which directly infects and destroys red blood cells.
Exactly. Or it could be a toxin from a snake bite or a bacterial infection.
So it seems like a lot of different things can trigger acquired hemolytic anemia.
Yeah, it's a pretty broad category.
And what are the symptoms?
Well, the general symptoms of anemia are common, of course, but people with acquired hemolytic anemia might also have jaundice, which is a yellowing of the skin and eyes because of the increased breakdown of red blood cells.
And how do you treat it?
Well, the treatment depends on the cause. If it's due to a physical cause, like a mechanical heart valve, then they might need to adjust the valve or replace it. If it's due to an immune cause, then they might give immunosuppressant medications. And if it's due to an infectious agent or toxin, then they'll treat the underlying infection or remove the toxin.
Okay, let's move on to hemochromatosis now. This one's interesting because it involves an overload of iron in the body.
Right. Hemochromatosis is a genetic disorder where the body absorbs too much iron from the diet.
And this excess iron can build up in the organs and cause damage over time.
Exactly. It can damage the liver, heart, pancreas, and joints.
And the symptoms don't usually appear until later in life, right?
Right. Usually people don't start to have symptoms until they're in their 40s or 50s.
And what are the symptoms?
Well, fatigue, joint pain, and abdominal pain are common. And people with hemochromatosis might also develop a bronze discoloration of their skin.
That's strange, a bronze discoloration.
Yeah, it's caused by the iron deposits in the skin.
And how do you treat hemochromatosis?
Well, the main treatment is phlebotomy, which is the removal of blood.
So you're basically draining off some of the excess iron.
Exactly. And they might also give iron chelating agents, which are medications that bind to iron and help the body excrete it.
Okay, last but not least, let's talk about polycythemia. This one's the opposite of anemia, right? It's an overproduction of red blood cells.
Right. Polycythemia means too many red blood cells.
And this can happen for a few different reasons, right?
Right. There's primary polycythemia, which is caused by a problem with the bone marrow itself. And there's secondary polycythemia, which is caused by something else, like chronic lung disease or a tumor that's producing erythropoietin, which is the hormone that stimulates red blood cell production.
So in secondary polycythemia, the body is just trying to compensate for something else.
Exactly. It's like the body is sensing that it's not getting enough oxygen, so it's trying to make more red blood cells to carry more oxygen.
And what are the symptoms of polycythemia?
Well, because there are too many red blood cells, the blood can become thicker and more viscous. This can lead to headaches, dizziness, blurred vision, and an increased risk of blood clots.
And how do you treat it?
Well, the treatment depends on the cause. If it's primary polycythemia, then they might use medications to suppress the bone marrow, and they might also do phlebotomy to remove some of the excess red blood cells. If it's secondary polycythemia, then they'll treat the underlying condition.
Okay, I think we've covered just about everything. That was a lot of information, but I feel like I have a much better understanding of these different blood disorders now.
Yeah, me too. It's amazing how much complexity there is within this one seemingly simple fluid.
And it just goes to show how important it is to maintain a healthy blood system, because when things go wrong, it can affect just about every organ in the body.
Absolutely. Blood is truly the river of life, and we need to take care of it.
Well said. Thanks for sharing your expertise with us today. I think our listeners learned a lot. And speaking of our listeners, we'd love to hear your thoughts on today's deep dive.
Yeah, what are your takeaways? What surprised you? What questions do you still